I will talk today about angiography of anomalous coronaries. I will provide a lot of cases, and that will hopefully also be a good exercise in understanding coronary angiographies and views, not just coronary anomalies. So coronary anomalies are seen in 0.3 to 0.9% of individuals, and much more so in patients with congenital heart defect. And particularly anomalous origins are most common, specifically anomalous origin from contralateral sinus of Valsalva, like anomalous origin of left circumflex from the right sinus of Valsalva, which is most common, or RCA from the left sinus, or least commonly left main from the right sinus of Valsalva. I will focus on anomalous coronary origin from the contralateral sinus of Valsalva. I will illustrate to you the possible courses of anomalous left main from the right sinus of Valsalva. This is an axial cut across the aorta and PA, showing you the anomalous course of that left main from the right sinus. First, you have to remember the relationship between the aorta and the PA. PA is on the left of the aorta, and it is anterior to the aorta, the PA base, as you can see here. So the PA is more to the left of the aorta and is more anterior than the aorta. Moreover, the PA base is higher than the aortic base. Hence, you can have, for example, the supracrystal VSD between those two. So the PA base is higher than the aortic base, which can explain to you how an anomalous coronary can course beneath the PA. It arises from the aorta and can course beneath that PA base into the septum, then emerge epicardially, the so-called subpulmonic or septal course. So here are the courses. One, you have the interarterial course, where that anomalous coronary goes in between the aorta and the PA. You have the retroaortic or posterior course, where that anomalous left coronary takes a tight loop behind the aorta, then emerges onto epicardially and feeds the LAD and the left circumflex. Then you have the pre-pulmonic course, where that anomalous coronary is anterior to both the aorta and the PA. And you have the septal or subpulmonic course, where the anomalous coronary dives beneath the PA, then emerges epicardially. Okay? Those anomalous courses apply not just for anomalous left coronary from the right, they also apply for an anomalous right coronary from the left coronary sinus of Valsalva. Okay? Another important idea here is when we're talking anomalous coronary from contralateral sinus, it could be arising from the very same ostium as the RCA, or from a separate ostium, usually in the neighborhood, so much so that a non-selective puff contrast injection can allow you to see that coronary and allow you to further target your catheters toward it. That picture applies to all anomalous left from the right, but also anomalous right from the left, but also anomalous left circumflex from the right, or anomalous LAD from the right. One specific anomaly, which is the most common anomaly, anomalous left circumflex from the right sinus, it's easier. Whenever you see anomalous circumflex from the right sinus, it is always retroaortic. You need to know that. Always retroaortic with an inferior usually takeoff. So you don't fulfill those 4 possible courses for anomalous left circumflex. So anomalous left circumflex from right cusp is always posterior. The interarterial course is the most common course of anomalous left main, and particularly anomalous RCA. Over 75 to 90% of anomalous RCA are interarterial, this course, which tend to be the most malignant course, as I will describe a little bit later. The other 3 anomalous courses, aside from interarterial, meaning the posterior, anterior, and septal course, They have been associated with sudden death less frequently than interarterial, mainly in the presence of some other high-risk anatomical features that I will describe a little bit later. This is the most important slide that I want you to know. So this is the axial cut that I described earlier, showing the anomalous courses. And this is how that axial cut projects into a longitudinal plane in an RAO view. So RAO view, very importantly, RAO view is the view that will spread the PA and the aorta in an anteroposterior plane and will spread apart the aorta on one side and the PA on another side angiographically, so that you can define the courses angiographically without needing to do a CTA. So RAO looks from here, and it will spread the aorta longitudinally. You will see the aorta here, and the PA will be there. You do not need to see the PA. You can imagine it just in front of that aorta. And the way you can define the aorta, you can do an aortogram, but typically what we do a coronary angiogram, and you define the aortic position using the catheter, which is in the aorta, and the non-selective contrast spill that you get as you're injecting that coronary. So this is how you can define the boundaries of that aorta. You can also do a non-selective shot so that you focus on seeing that aorta and aortic boundaries, okay? So we see where that aorta is in an RAO view, and accordingly, we can tell what the course is. This is how each course projects. If you have an interarterial left coronary or any interarterial anomaly, interarterial right coronary arising from the left, the way those will project, they will project as a sharp bend in front of the aorta, and it will project as a tight tunnel, bend, or a dot in front of the aorta. Sometimes we call it the anterior dot. It's not always a dot. Sometimes it's a tunnel. Sometimes it's a kink, but it's tight and hugging that aorta anteriorly. This is the interarterial course. The retroaortic course will project as a posterior dot or tunnel or tight loop behind the aorta. That's the easiest one to recognize. Then you have the anterior or pre-pulmonic anomalous coronary, and that will project as a smooth, wide, upward eyebrow. You see, it's an eyebrow or loop, wide in front of the PA. Now, you don't see the PA, but you can imagine it when it's doing this wide loop before, in the case of the left coronary, splitting into giving the circumflex down and the LAD. This is an anterior pre-pulmonic anomalous coronary. If you have a subpulmonic course, then you will see that anomalous coronary giving also a wide eyebrow or loop. In this case, the eyebrow is a downward eyebrow or loop. It dives downward, wide, smooth loop before giving a left circumflex upward. It gives a left circumflex upward, which will loop back down eventually, and it gives the LAD. You do not need to put a swan in the PA catheter. The old teaching is to put a swan or PA catheter in the PA to help delineate the aorta and PA. And you put a swan and you can do RAO view to delineate the course, but you don't really need it. Old teaching also says you can put a swan and do a steep left lateral view, which will also set apart aorta and PA, but you really don't need that. You can do just those aortic delineation in your coronary angiography in an RAO view. If you want to remember one thing from this talk is this slide and this idea. If someone shows you an angiogram and asks you what is the course of the anomalous coronary, your answer should be, show me the RAO straight view, usually 30-degree RAO. Always image an RAO view, which will show you the anteroposterior spread of the aorta and PA. If you go LAO, LAO looks from here. Well, you're not going to be able to tell the course. LAO, whether you have interarterial or posterior or anterior, they all will project the same in an LAO view. You need to go from here to spread the aorta and PA apart. LAO superimposes the PA and the aorta and won't allow you to delineate the course. So this shows you this again, LAO versus REO. Now, LAO is still very important. LAO spreads apart the right and left cusp, and it's the view that you start with in anomalous coronary, because it is the view that tells you first whether the coronary arises from the right and left cusp. It's the view that tells you whether there is an anomalous coronary to start with. So it will tell you, okay, my left coronary is not arising from the left cusp. There is nothing coming from here. Okay, I see the left coronary coming from the right cusp next to the right coronary. So I know the left coronary is arising from the right cusp via an LAO view, but then the REO view will define the course. So LAO will tell you its anomalous origin, REO will tell you what is the course of this anomalous origin. You really do not need a CTA to define the course. You can use a CTA to assist you, but I can almost always define the course by angiography. What I just described has been also called the dot and the eye technique to localize the course of the anomalous origin, right or left coronary, according to a paper from the 1990. So they did an aortic angiogram in this case in an REO view, and they showed the same thing I just showed you. Basically, this is how the retroaortic course projects as a dot or a tight tunnel behind the aorta. This is the interarterial course, can project as a dot or a tight tunnel or a kink. It's not always a dot, it's like a kinky artery in front of the aorta, tight in front of the aorta. This is how that anterior course projects. It's a wide loop. And this is the subpulmonic course, wide loop or eyebrow downward. Okay. I will give you now case illustrations. I have several cases. So this is the first case. We kept trying to engage the left coronary here on the left sinus with no success. In those difficult cases, what you should do in general is do a non-selective cusp injection in an LAO view to help gauge whether the takeoff of that left main is from the left cusp. Do also a non-selective cusp injection in an REO view to see, well, maybe it is that left main coming from the left cusp, except it's coming maybe anteriorly from that left cusp. Maybe it's coming from here or posteriorly. So do non-selective left cusp injection in LAO first, then REO view. Now, if you don't see that left main coming from that left cusp, then think, okay, well, it must be coming from the right. So we did that. We see no artery coming from the left cusp. So we thought it's coming from the right. And we shot the right coronary. We didn't see anything coming from the right coronary. So we thought, well, maybe the left main is coming from the right cusp, but next to it. Most often it doesn't come from the same origin, it comes next to it. So what you do, you pull back the catheter a little bit and you try to do a non-selective right cusp injection to see where that left main is. And indeed, that's what was done. And you see here a left coronary coming from the right cusp next to the RCA. Okay. So we define you have an anomalous left coronary from the right cusp. We define there is an anomalous origin. Now we have to define its course. This is an LAO view that tells us there is an anomalous origin from that right cusp. Now we have to define the course. And this is when we use the REO view. And we did here REO view. And you can see, now you know the course. I hope everybody can tell. So we're injecting, you see the RCA. It's a lot of overlap in this view, but know what to focus on. This is an RCA. The RCA is coming here. And the anomalous left coronary is that one that goes eventually and gives what looks like an LAD in an REO view. Okay. So it's looping behind the aorta. Again, you define that aorta. You see your catheter. This is where the aorta is. And you see the contrast spill, which defines the aortic boundary. Okay, well, this is the aorta. Well, clearly, the retroaortic course is the easiest course to define in REO. It's clearly looping behind it, giving that tight noodle or loop. So this is retroaortic course of a left coronary. But our job is not always done here, because sometimes what you're seeing could be just LAD or just left circumflex. Sometimes you don't only get anomalous left coronary from the right cusp, you can get anomalous separate LAD from the right cusp and anomalous left circumflex from the right cusp. Okay, so what is this artery we see? This is an RAO view, which for you in your heads, it's a little close to the RAO caudal view. So what appears here on the top part of the cardiac silhouette, this is the cardiac silhouette, this is the LAD, okay, and this is a diagonal. Is there a left circumflex? You have to think, or should I fish for another artery that is left circumflex? So we selectively engage that anomalous coronary, and we see it is definitely looks like an LAD with diagonals. Is there a left circumflex? So we did an LAO caudal view, and we proved there is a left circumflex. And the way you prove left circumflex in all those anomalous coronary angiogram, one important tip is that the left circumflex is always on the coronary sinus. It's in the left AV groove where the coronary sinus is. So in all those complex angiography in patients with anomalous coronary, when you're confused what's what, wait for the venous phase and see the coronary sinus. You see here, I highlighted it. At the end of that angiography, you see the late venous phase, and you see the coronary sinus filling here, okay? Wherever the coronary sinus is where your left circumflex is. So on this view LAO-caudal, I see the coronary sinus, and I see indeed that there is a left circumflex. It's a tiny left circumflex that gives a tiny OM, but there is a left circumflex. So I don't need to go fish for another artery here, okay? So remember that, venous phase, coronary sinus, left circumflex, okay? So we define, this is an anomalous left main. So this is actually a long left main that goes retroaortic and gives an LAD and a left circumflex. Another important idea is, after you define the origin and the course, you want to selectively engage that anomalous coronary. One, to get a better angiography, but also if you need to intervene, and that's an important interventional cardiology board question. They want you to know what guide catheter for which coronary anomaly. So generally speaking, when you have a retroaortic posterior coronary anomaly, it has an inferior takeoff, and you need an inferior looking catheter, such as a multipurpose or RCB, right coronary bypass catheter. If you have an anterior or pre-pulmonic course, generally it's not just anterior, it's upward looking, and you need something like an Amplatz left to engage it, okay? And this is what was done here. Here we used Amplatz left to engage this downward looking coronary. If you're good with the Amplatz left, you can make it point down. In an elongated way, it looks down. In a duck-shaped, properly shaped way, it will look up. This is another case. This one is extremely important for general cardiology board. I will guarantee to you that you will have that image on your imaging section of cardiology board. So you take your left coronary angiogram and you see a long, very long left main, okay, very long left main. What is your immediate reflex? You should always know that. Very long left main, my immediate reflex is that there is no circumflex that I'm seeing. It's an anomalous left circumflex. And actually what I'm seeing here is not a left main. This is actually an LAD, and the left circumflex is coming from somewhere else. So again, reflex, you see a long left main, think anomalous left circumflex, and what I'm seeing here is the LAD, left circumflex is somewhere else. And again, like I explained earlier, the coronary sinus will help you. In those cases, wait late on your cine and wait to see that venous phase and the coronary sinus filling, which will tell you, okay, the coronary sinus is here, the AV groove is here, but I do not see a circumflex, okay? Another way, in this particular patient, this patient has a lot of MAC. He has annular calcium that you see here. This is probably posterior annulus and a little in the anterior annulus. So when you have MAC, you don't need even to wait for the coronary sinus. The MAC is in the annulus, it's in the AV groove. So the plane of that MAC would be the plane of the circumflex. Well, I don't see anything in the plane of that MAC, so there is no circumflex, okay? Note here that this is the MAC, and he has also calcified aortic valve. So MAC is here in an RAO view, and aortic valve is here. All right. Okay, so when you see that there is no left circumflex, you only have an LAD, which looks like a long left main, there are 4 possibilities. You need to know those 4. One is the circumflex arises from the left coronary sinus, but it's a separate ostium. It's what we call separate LAD, left circumflex ostia. 2, the left circumflex arises from the right coronary sinus. 3, the left circumflex is occluded, but in those cases, you know, it's a flush occlusion ostially, but in those cases, you will typically see some collateral filling. You know, unless that territory is totally necrotic and thin, usually you will see some collateral filling, whether from the LAD or from the RCA. 4th possibility and least common possibility, I've only seen it one time, is that the left circumflex is very small or absent practically, and you only have an LAD and an RCA that is super dominant and gives basically distal AV groove branch that goes all the way up to the left AV groove and gives OMs basically. So, okay, in that patient we just did, so when we see this, the first thing I do is I try to get a non-selective left cusp injection, and I try to see whether I see a left circumflex from the left cusp, because this is the most common origin usually. You can also pull back that catheter slightly and maneuver it around to see if you can get into a left circumflex, okay? Well, we did that. We couldn't get a left circumflex. So we thought the left circumflex, next most common, must be arising from the right cusp. So we engage the right coronary, and we see the left circumflex coming from that right coronary in an LAO view. So that LAO view define anomalous origin. Okay, our left circumflex is from the right sinus. And it's a big left circumflex. It gives a lot of obtuse marginals, as you can see here. So the next step is to define the course, or wait, we decided that an anomalous left circumflex is always retroaortic, but it's nice to prove it. So we did an RAO view, and this is the RAO view. Again, it shows a lot of overlap, but try to isolate your points of interest. So the RCA is this artery here. Okay, this is the RCA. And you see the circumflex as that noodle, that loop, okay, that is going behind the aorta and coming to the left AV groove and giving a bunch of obtuse marginal branches. And notice it's a nice, in an RAO view, which looks straight in the AV groove, it not only sets apart the aorta and the PA here, it also sets apart the AV groove and the atria versus the ventricle. So in an RAO view, it's nice because you see the RCA is parallel to the left circumflex. They both run in the AV groove, one on the right AV groove, the other on the left AV groove. So look, they are almost superimposed on an RAO view. It's a nice thing to understand and see. We rarely see the circ and RCA on the same angiogram, okay? So it's a retroaortic course. Again, downward takeoff. The best catheter to engage this is a multi-purpose catheter for your board. This is another illustration of a similar thing. Again, long left main, reflex, anomalous left circumflex. And here we waited for the venous phase. And you see the coronary sinus. I want you to recognize that coronary sinus. You see that coronary sinus coming here late, okay? Well, there is nothing on the course of the coronary sinus, so there is no left circumflex. Same thing, we were able eventually to engage that from the right sinus. It has the same origin as that right coronary artery, okay? So this is that anomalous left circumflex. It's relatively small. And we did an RAO view. Again, get your eyes used to that posterior noodle or loop behind the aorta. And this is the posterior loop I'm talking about. So the circumflex comes, loops posteriorly, and this is that posterior dot we talk about, that foreshortened tunnel gives the impression of a dot behind your aortic boundary, which is the aorta is here as defined by the catheter and contrast spill. So it loops, it has that posterior dot, then it gives one obtuse marginal here, then another obtuse marginal here, then it continues down in the AV groove. The true circ is the one that is parallel to the RCA. Okay, so understand here anatomy. True circ is this one parallel to the RCA. This is a true circ after it has given two obtuse marginal branches. Like I said, through this talk, I don't want you to just understand coronary anomalies. I want you to understand angiography. It's a good exercise in angiography. So here we did a p-caudal of that anomalous circumflex to better see the obtuse marginal in a caudal view. And again, you see here we use a multi-purpose catheter, which is pointing down and going actually deeply in that anomalous left circumflex. Okay. This is another case. This is the only case I've ever seen of that sort. So again, long left main, suggestive of an abnormal origin left circumflex. We could not find it in the left cusp, nor in the right cusp. But this is why, look at that RCA. That RCA, actually, in an RAO view, it's going all the way down, and distally, the AV groove RCA is going all the way back up in the left AV groove and is giving obtuse marginal branches. So much so that if you superimpose those views in an RAO view, that RCA goes all the way back almost to the left main. It's practically a circumflex that's coming as a distal continuation from the RCA. Very, very rare. Okay. This is another case. It's more complex, but it will provide an application. So this is a patient where no artery could be found on the left cusp, including on non-selective left cusp injections. So we are thinking left main from the RCA. And we saw that indeed there is a left coronary arising from the right sinus of Valsalva, and it's almost the same origin as the RCA. Great. Now we did RAO view of that. We see that that anomalous coronary from the right is looping posteriorly, as in a posterior loop, and it's going down the AV groove parallel to the RCA, which is the circumflex. Okay, so it's looping posterior, it's posterior course, and it's giving a circumflex for sure. And in a process, it gives those arteries. Now, are those just obtuse marginal branches, or is there an LAD with them? Again, in an RAO view, you don't just define the anomalous course, you can also define what are my arteries. Is this just left circumflex, or is it LAD circumflex, or is it just LAD? Because like I said, the LAD and the left circumflex could have separate ostia. Well, looking here, I mean, this is RAO. Look at that cardiac silhouette, and the LAD should be running here, not at the border of the top, but somewhere on top here, and going to feed that apex, at the very least reach the apex, if not loop around it. Well, I don't see anything going this way. So maybe this is just a circumflex, and you're getting obtuse marginal branches. I don't see anything going to the apex. So think, well, maybe there is an LAD coming from another place. Okay, well, we kept fishing in the right cusp for the LAD, and we did find it. It's another origin LAD from the right cusp. And here you can see it. So it's a separate origin LAD, separate from the circ and the RCA. And this is an RAO view, and you can tell the course. So this is the LAD, and it's going actually to the apex. The problem is that this patient was having STEMI, and it's subtotally occluded, and the artery is not filling properly. Actually, after we fixed it, look how it looked. This is the LAD. It's going all the way to the apex. Anyway, on that first shot, you have to define what is the course of that anomalous LAD in an RAO view. And here I want you to recognize, I hope everybody can recognize the course. So, okay, this is your aorta. This is clearly not posterior. This is anterior. Now, is it anterior as in anterior to both, what we call the pre-pulmonic course, or is it interarterial, or is it subpulmonic? Well, look at it. If it is interarterial, it will have a tight loop or dot in front of the aorta, or a tight kink like this. This is not the case here. It's a nice, wide, ample, smooth loop. So this is more this. This is what you see, wide, upward, smooth loop. This is a pre-pulmonic course of that anomalous LAD. Now, notice here another important idea. So 3 things. 1 is anomalous origin from the right cusp. 2, anomalous course. You define the course, interarterial, posterior, etc. 3, you have to define the takeoff in order for you to decide, well, what catheter I can use to engage that takeoff ostium. So this takeoff is upward. Usually, like I said, posterior takeoff or looking downward, you use downward looking catheter. Anterior takeoffs and interarterial takeoffs, they look usually upward. So you need an upward looking catheter, such as Amplatz left 1 or 2, or in this case, Icari right 1.5 was the only thing that worked in that case. It's a very sharp upward takeoff. Okay. So those are the catheters for anterior LAD or left main course from a right cusp, upward takeoff, AL, Icari right, IM, and frequently you need to use guide liner. This was another case in this patient at another point in time. And in this case, what was used was an IM with a guide liner, and the guide liner allowed us to create a sort of an Amplatz left shape looking upward. Okay, and this view here is nice. It shows you all 3. It's non-selective right cusp injection that shows you all 3 arteries: RCA, left circumflex, which has a posterior course, inferior takeoff, and LAD, which has an anterior course and upward takeoff. This is an LAO view, so you don't see the course as well, but you see all 3 arteries and their takeoffs. I want to move on to describe some clinical ideas before going back and showing you more angiograms. Why is it important to define those anomalous coronaries? 1, because it's difficult to engage them and you need to understand them well in order to do proper coronary angiography. 2, because they have clinical repercussions. Specifically, there is a risk of sudden death with anomalous coronary artery. It's a low risk, but it's an important risk to recognize. Traditionally, the highest risk of sudden death with anomalous coronaries is with the interarterial course. It used to be thought that interarterial course, you have a risk of sudden death because with exercise, you get compression of that interarterial course between the aorta and PA. That did not turn out to be true, because the aorta doesn't expand that much to compress that anomalous coronary. The true explanation is the following 3 ideas. The anomalous coronary, particularly when you have an interarterial course, causes an acute angle, sharp bend, which causes kinking, particularly here, kinking and torsion of the aberrant artery, particularly here at the sharp bend area. So you get it more with interarterial than you get it with the smoother courses, okay, like anterior or subpulmonic. So another idea is that acute angle, not just you can have a kink here, the acute angle itself stretches that ostium. So it goes from being round to being oval or elliptical, like here. And when it's elliptical during exercise, as the aorta stretches out, enlarges and stretches out, that elliptical gets further stretches and becomes further narrowed. So it gets stretched this way and becomes more slit-like and more narrow. This is what we call the slit-like elliptical orifice. That can cause ischemia. Third idea is part of that anomalous coronary, especially when it has a sharp bend, part of it courses inside the aortic wall, and part of it will be inside that wall, and the lumen will be occupied partially by that aortic wall, which causes narrowing of that origin and causes ischemia. This is what we call intramural aortic course. Okay, so those are the three ideas that cause sudden death, mainly with interarterial course. ACC guidelines emphasize the long intramural course or the slit-like orifice or the acute kinked angle as surgical indication defined by CTA rather than the classic interarterial course. But again, for the longest time, interarterial course has been the malignant one and has been correlated with sudden death on autopsy studies. And it correlates with those anatomical features. Also, young age is insisted upon in the guidelines for surgical correction. Stress testing, that's an important idea. If you do stress testing, you have to do exercise stress testing, not vasodilator stress. It's exercise that expands that aorta and causes ischemia, not vasodilator Lexiscan. However, recognize that exercise stress testing is insensitive for the diagnosis of ischemia or prediction of sudden death related to an anomalous coronary artery, particularly left main. It is specific if you have a clear-cut chest pain or EKG abnormality with exercise, but it's not sensitive. Now, the most important question is, what is the risk of sudden death? So we know there is a risk of sudden death with anomalous coronary origin, but what is that risk? And here I will provide you the numbers and the pitfall, how to interpret those numbers. In autopsy series, mainly old autopsy series from the 80s, say 70s and 80s, 27 to 80% of patients with anomalous interarterial left main had died suddenly, and up to 20% of patients with anomalous RCA had died suddenly. However, this does not mean that 27 to 80% of patients with anomalous left main will die suddenly. This does not represent the absolute risk of sudden death from an anomalous coronary artery. Rather, it's the relative frequency of sudden death among patients with anomalous coronary artery who happened to have an unexplained early death and receive an autopsy. There is this autopsy selection bias. It is possible and maybe likely that the lifetime risk of sudden death from an anomalous left main is 0.5% or 1% only, when the denominator is all patients with anomalous left main. But if out of all patients with anomalous left main, you only autopsy the 0.5% that died in unexplained death and died suddenly, then the risk of sudden death will evidently look overinflated. So we don't know the absolute risk, but it's probably not very high, okay? And the data as well, the guideline insists on the age. Actually, based on those autopsy series, sudden death almost always occurs in young patients less than 30 or 35. And those are the guidelines. Guidelines give a class 1 recommendation for surgical correction of anomalous left or right coronary origin. If you have typical exertional angina, they have to be typical symptoms. Be careful here, not any dyspnea or fatigue or any atypical chest pain at rest. It has to be typical exertional angina relieved with rest. So they give a class 1 for that, or typical exertional stress test, not vasodilator stress, typical exertional stress test with ischemia. It gives a class 2A for asymptomatic left main with high-risk anatomical feature, such as interarterial course, and a class 2B for anomalous left main without high-risk anatomical feature and any RCA that are asymptomatic. So basically, asymptomatic RCA, including the interarterial course, which is the most common for anomalous RCA, which you're going to see a lot in your career because it is the more common anomalous coronary, much more common than anomalous left coronary from right. Well, if it is asymptomatic with no ischemia on clinically or by stress test, it's only class 2B recommendation to fix it. You have to really probably not do it. It's asymptomatic and over 35. So this is my summary. True exertional angina or truly abnormal stress test or VT, exertional VT, which is what causes sudden death, yes, for surgical repair. Asymptomatic with no ischemia, but interarterial or other high-risk features, left main, yes, RCA, possibly, If less than 35, probably not. If over 35 and asymptomatic, okay? And this is those are the guideline texts that support my view, although they guidelines avoid making a final decisions in that regard. So I made it more straightforward because we do need to make straightforward decisions in life. Another idea here, what does surgery consist of? Surgery typically consists of unroofing the anomalous coronary intramural course and relocation to the proper sinus. Most surgeons, though, however, don't do that unroofing and relocation. They do bypass surgery to the anomalous artery. But keep in mind, you bypass an artery that is normal. It only has an anomalous course. Most often the flow is normal, except in extreme exercise. So the risk of that is that the bypass will not mature. So what they frequently do, they put a mammary graft to last lifelong, and they ligate that native anomalous artery. So it's not an easy surgery. It comes with hazard. And that's another reason why you have to pick the patient carefully for it. This is an illustration, 45-year-old woman, very classic case, atypical chest pain, not consistently exertional, Lexiscan spec is that vague, common reading or mildly reversible, mild anterior defect. Coronary angio shows anomalous RCA from the left cusp, interarterial course. Next step, it's simple to me here. There is atypical chest pain, not a definite stress test, likely artifact, doesn't correlate with the RCA anyway. Age over 35, leave her alone, do absolutely nothing. Maximum, you can consider exercise, stress testing, and see if there is ischemia in that RCA territory, but otherwise do absolutely nothing. So this is another case. You could not engage. So this is a patient where we tried to engage the right coronary with a GR4, no success. It's a common case. I tell fellows when this happens, you should immediately think of RCA that is not anomalous, that is arising from the right cusp, but anteriorly, anterior RCA takeoff. And in that case, try to use an amplat left 1 catheter and aim to the anterior surface of the aorta. Okay, so we did that, aiming for the anterior surface of the right sinus of Valsalva, but we could not engage anything. So we aimed for this point with no success. So what's the third step? The third step is to think, well, I can't engage that RCA in the two standard positions. It must be an RCA arising from the left cusp. And what we do in this case, so what we did, that same amplats left, we try to fish for an anomalous right on the left cusp. And we try to take non-selective cusp injection of the left cusp to see whether that RCA is arising from the left cusp. Well, we could not engage it on this portion of the left cusp. So it might be coming from a left cusp, but it's not anterior left cusp. Maybe it's very close to the left coronary. So we went back and we used the same catheter we had used to engage the left coronary. We had engaged the left coronary with a JL 3.5. We did not see a right coronary coming from it, but we brought back that catheter and we tried to do a non-selective left cusp injection close to the left main. And indeed, we see here it is. So it's not very close. That's why when we injected the left main, we could not see it on our initial left coronary angiography. So we see it's higher than it, okay? And this is a left cusp injection. So we can see one, definitely that RCA is arising from the left coronary sinus of Valsalva, and it's high up. Now we have to define its course and try to engage it selectively. Those are the two next steps. So in terms of its course, in an REO view, again, this is the aorta, this is the catheter and the non-selective contrast spill. The RCA taking a sharp turn or bend or dot anterior to the aorta. Look at it again. You see the boundary of the aorta, and the RCA is taking a sharp bend, hugging that anterior aorta, then coursing in the right AV groove. So this is actually an interarterial course of an anomalous RCA, which again is the most common anomalous RCA course. Now, another idea here, okay, is how to engage that anomalous RCA, which is the third step. Beside defining anomalous origin from a contralateral sinus, you have to define the course, then what's the takeoff? How can I engage it? Generally speaking, in order to engage the anomalous left cusp RCA, you need to know that slide. This is for interventional cardiology board. I actually had that question. They need you to know when you have anomalous RCA from the left sinus, the 3 configurations and which guide for each. So when it is like the one, when it is the here, C, which is in this position, okay, and the left cusp, but anterior, close to the ridge of the left-right cusp, in this position, you use Amplatz left. In those other positions, you can try Amplatz left, but typically it's the same Judkins left you use for the left coronary, but shorter. So it will be Judkins left 3, for example, to engage A. You loop it upward to engage that, and Judkins left 3 that you elongate downward to engage B. That's classic, but you may need a bigger Judkins left 4 to make it look down and engage B, or even to make it loop up and engage A. So those are general rules. Generally, it's a shorter Judkins. That's a general rule for an anomalous right or an Amplatz left, particularly when it's anterior on the left sinus. I will give one more case of anomalous coronary origin. So this is and as I said, I have a large collection of those cases. And I'm sharing those with you. I want you to review them on your own and, share that practice. It's good. It's good exercise in angiography. So this is a right coronary injection, and we see an anomalous coronary coming from it and going to the left heart. Again, remember, this is an LAO view, and we see something going to the left heart. 1, you have to define the course. 2, you have to define here, well, what is this? Is this an LAD or is this a circumflex? I find it easy in those tough cases to do RAO in order to tell you whether this is LAD or left circumflex. RAO will help you define that more, okay? So in an RAO view, this is what you see. Beside the course, well, you can tell what is this artery? Well, remember, in an RAO view, you're seeing the AV groove. You're seeing the RCA in the AV groove. If you have a circumflex, you can use the RCA as your landmark. I mentioned you use the coronary sinus. Yes, you can use the coronary sinus, wait for the venous phase to see whether what you're seeing is a circumflex or not. You can use MAC, but you can also use the RCA, as I showed in other angiograms previously. The true circ will run in the AV groove parallel to the RCA, almost overlap with the RCA, depending on how sharp your RAO view is. So I don't see anything going in the AV groove here. So what you see is actually an LAD. Furthermore, in this RAO view, you have to define what is the LAD, what is the diagonal. Actually, the bigger one is a diagonal because it's hugging the heart silhouette border. The true LAD is this one, the one that is not hugging the border, more in the top of the cardiac silhouette in RAO view, but not hugging the border, okay, in the center of that top. And this is the LAD. Here, you see it. This is the LAD going toward the apex. Doesn't quite loop around the apex because you have a PDA from the right that goes and almost loops around the apex. Okay, so we define this in LAD. Now, what is the course of that LAD? That's an interesting question here. Someone may look and think, oh, this is a, it looks like an anterior noodle. This is a pre-pulmonic course. I'll tell you, I think this is interarterial course. It's not the most classic interarterial course, but it is interarterial course. But this is how it looks, because this is the aorta. Okay, you have your catheter and your contrast spill. And you see that tight loop. Whenever your loop is tight or kinked in front of the aorta. So whenever you have a loop that is tight or kinked, this is interarterial. If you had an anterior pre-pulmonic course, your loop will be smooth, as I showed in a prior case. Remember that case I showed earlier? It was an anterior LAD. Your loop was wide and smooth pre-pulmonic. This loop is tight. It has a kink. Okay, it's because it's going in between the aorta and PA, then emerging from around the PA all the way to the septum. So it's going in between the aorta and PA. It's not giving that classic dot look, it's giving an impression of a tight artery or a tight tunnel, tight loop, okay? So this is an interarterial course. I hope everybody understood that. Look, again, you can put a Swan catheter to confirm. You can do a full aortic angiography to further delineate the aortic boundaries and help. So full aortic angiography, Swan, and sometimes to aid, you can add a left lateral view. And in this particular patient, the left circumflex is coming off the left coronary sinus, so as normal. So when we engage the left coronary, we could see what looks like a left main and left circumflex. What this is just an isolated left circumflex, kind of like what I showed earlier, an isolated LAD with an anomalous left circumflex. Except this anomaly here, where an LAD arises from a right sinus, is rare, much more rare than an anomalous left circ from a right sinus. I want to talk about coronary artery fistula. What is a coronary artery fistula? It's a communication between a coronary artery and either a cardiac chamber, and most commonly a cardiac chamber, which is RV or RA. And we call this coronary cameral fistula, like a camera, coronary cameral fistula. Or it's a communication between a coronary artery and a vascular structure, such as the PA or the coronary sinus. Those are less common, but this is what we call coronary arteriovenous, AV fistula. 60% of those fistula arise from the RCA, most of the rest are from the LAD. So most often RCA, next is LAD, rarely circ. But the very important thing to remember is that they very often finish on the right side of the heart, almost always, not always, but 97% of the time, and overwhelmingly in the RV and sometimes the RA. So if you remember one termination, remember right side, most often RV. Now, very importantly, again, you need to recognize your views. How do you define where that fistula lands? RV, RA, LV, how do you know? Again, you need to use LAO and RAO view, like we talked about in anomalous coronaries courses. So LAO view will look toward the septum and will spread apart right heart from left heart, like it spreads apart aorta from PA, and right cusp from left cusp. It spreads apart right heart from left heart. It will tell you where that fistula terminates, right heart or left heart. RAO view looks in the AV groove and spreads apart posterior from anterior, specifically in the fistula case, to spread apart atria, particularly RA, from RV. So you do image the fistula in two views to define its landing, where it's terminating, okay? I will give you an illustration here. So this is an RCA image in an LAO view, and you see a fistula. You see basically spider web type of fistula, what you call the plexiform type of fistula. It's a web of small branches coming off that RCA and landing somewhere here. Well, where is it landing? One, it's LAO view. This is the PDA. The septum will be here. The PDA runs beneath the septum. So the septum will be somewhere here. So this is definitely the right heart, not the left heart. So it's finishing in the right heart. Then you do RAO view, and you can see where is this fistula finishing? RV or RA? Well, it's clearly finishing in the RV, okay, not RA. Now, could it be finishing in the PA? Remember, I will tell you no, it cannot be finishing in the PA. Why? Because as I described earlier, one, the PA is not on the right side. The PA base, at least, is not on the right side. The PA base is more leftward than the aorta, okay? Now, the high PA goes eventually to the right, but the PA base and the proximal PA is on the left side of the aorta. Two, the PA is higher than the aorta. The PA valve, the pulmonic valve, is higher than the aortic valve. So this is terminating below. If you see the running film, it's terminating below the aortic valve. So it cannot be in the PA. So this is actually a fistula from the RCA to the RV, high RV, maybe RVOT. Okay. Now, is this what to do with this fistula? Is this a large fistula that needs surgical repair? Now, here is how you decide if a fistula needs a repair. And by the way, most fistula, coronary fistula are small and benign. A fistula is large if it has any of those three consequences. One, let's say you have a fistula from a coronary to the RV or RA, well, you will get a significant left to right shunting with O2 step up, pulmonary hypertension, and both right-sided enlargement. When you have fistula to RA as an ASD, you get right-sided enlargement, or you can get right and left-sided enlargement when you get fistula to the RV. And you can prove that by doing a right heart catheterization. The second consequence is that that fistula can steal blood from the distal coronary and can cause a coronary steal and myocardial ischemia. And as a result of that myocardial ischemia, angiographically, you will have this finding. The proximal segment of the coronary, in order to accommodate for that steal, will enlarge dramatically and will become aneurysmal. And as a result of that aneurysm, you'll develop atherosclerosis, thrombosis, and that bulky thrombotic atherosclerosis. And that you can define it angiographically, aneurysm or aneurysmal complications. Most fistula are small and do not need correction. Unlike anomalous course, however, complications of fistula may occur later in life as those fistula enlarge. They can enlarge insidiously and lead to symptom at a later age, but still overwhelmingly, most often they are benign. Some other anatomical descriptors of fistula, besides what I just described. Some fistula are called simple and consist of a single origin and a single track, which I will show in one more case. And other fistula are complex, like the one I showed. But when we say complex, it doesn't mean necessarily large or it needs to be closed. This one is complex in light of the fact it doesn't have single track, single origin, single termination. It's a spider web, a plexiform web. So this one, we call it complex fistula, plexiform network, or multiple origins, multiple terminations, or the coronary artery itself fistulized. So that's how I explain this. Imagine that right coronary artery finishes in the PDA and the PDA itself finishes in the RV. This is what we would call right coronary itself is fistulizing, finishing in the RV. This is also a complex coronary fistula. Okay, so this is just some terminology for you to know. But what's more important is what I described earlier. A large fistula is any fistula with any of those three hemodynamic effects, mainly two in the cath lab: left to right shunt on right heart cath, or angiographically aneurysmal dilatation with or without bulky atherosclerosis and thrombosis. Okay. Another definition that you can use in the simple fistula is a fistula tract that is 2 times the caliber of the distal vessel. Large fistula should be closed, typically closed surgically, and surgical closure consists of ligating the origin or track of the fistula, or in case of multiple tracks, patching the distal termination from inside the cavity. You cannot ligate all those multiple complex plexiform tracks. You can just patch the termination from inside the cavity, and the plexiform web may thrombose. Percutaneous closure is possible with those simple fistula, and that's why that classification is more useful for decision about percutaneous management. So percutaneous closure is possible when a single large communication is identified and you use coil, oversized coil embolization. This is a case here of a transplanted heart. You see the left coronary, and your eyes always in angiography have to catch distal late filling, okay? So you see something filling late, okay? It's a fistula. Now, you see it better here. This is an aerial view. And you see that thing filling late here. Okay, it's a fistula. Now, between the LAD and something else. What is this something else? Well, in an LAO view, that something else, you see the LAD, the septum. In an LAO, this is on the right side of the heart. It's on the right side of the septum. On this view, on the RO view, you can tell that actually it's a fistula, not to the RA, which would be here. It's a fistula to the RV, anterior to the AV groove. So it's a fistula between the LAD and the RV. Now, is this a large fistula? You have to ask yourself. The answer is no. Two things angiographically here. One, the artery is not aneurysma. The LAD is not aneurysma. Okay. 2, the fistula itself, it's a simple fistula, by the way. It's between the LAD and the RV. It's not like the prior one I showed, the plexiform network. It's one track that starts from the LAD and finishes in the RV. However, that simple fistula, you can use another definition for large when you have this. Is it less than 2 times the size of the distal LAD? It's actually less than 1 time the size of the distal LAD. So it's a small, simple fistula with no angiographic indirect suggestion of hemodynamic effect. You can do a right heart cath to further prove that there is no O2 step up or significant QP/QS. If this was significant, or if it becomes significant with time, this is a perfect fistula for coil embolization. It's a simple track, clear origin, and clear termination.